This video presents management of an unusual and rare clinical entity, double crystalline lens. Our tertiary care referral institute at Chandigarh, India serves several thousands of pediatric cases with ocular ailments each year. Here is a child brought by parents at the age of 4 months noticing an abnormal large right eye since birth. Subsequent examination of the child revealed an oblique right eye with 2 corneas joined together and a normal left eye. Under anesthesia with dilated pupils, presence of double crystalline lens was noted, separated by a small central clear aphakic zone suggesting incomplete duplication of anterior segment. Largest horizontal corneal diameter was 16.5 mm. Both eyes showed normal fundus with a good foveal reflex. Neuroimaging, including CT scan and MRI, also showed presence of double crystalline lens. Fundus examination of the mother revealed presence of choroidal coloboma in both eyes. Now what next? Should we leave it alone? Maybe a lensectomy and vitrectomy? Or a phacoaspiration plus PCIOL? How? This case is surely a management challenge. Is it possible to implant a single piece IOL into 2 capsular bags? If yes, will the child achieve useful vision? Plan for IOL implantation was conceptualized right from designing a special suitable IOL which could be placed into the capsular bag of both crystalline lenses. After multiple brainstorming sessions, we conjured an IOL design with maximum overall diameter of 18 mm. The central optical zone is 6 mm with surrounding 2 mm extensions. Haptics were designed to allow transscleral fixation if required. We obtained biometric measurements including keratometry and axial length. IOL planned for implantation was 30 diopters after 20% reduction. The initial steps resembled those of any pediatric cataract surgery. Reformation of anterior chamber was ensured with 1.4% hyaluronate. Iris hooks were placed. Clear corneal incisions were made with disposable keratomes. Following this, we performed 2 anterior continuous curvilinear capsulorhexes. One by one, started with cystitome and completed with Utrata's forceps in both the crystalline lenses separately. Here we can see 2 rather elegant capsulorhexes completed. Multi-quadrant hydrodissection was followed by standard steps of phacoaspiration. This ensured complete clearing of lens matter from both the capsular bags, one by one. Specially designed acrylic foldable IOL was loaded in the cartridge, followed by injection of viscoelastic material and the IOL implanted in a way so that the leading haptic goes into one capsular bag and the trailing haptic into the other. Both haptics are now secure and the optic lies in the central part. Presence of zonules connecting the 2 capsular bags is clearly demonstrated. Incision closure was ensured, removal of viscoelastic material and standard steps of closure followed. 6 months post-operatively, the intraocular pressure was 10 mm of mercury and the spherical equivalent obtained by retinoscopy was 5 diopters. Examination under anesthesia reveals clear visual axis, round pupil and a well-centered IOL. There was some PCO in the periphery of each capsular bag. 1 year after surgery, The intraocular pressure was 12 mm of mercury and the mean spherical equivalent was 1.5 diopters. Under anesthesia, well-placed IOL with clear visual axis and presence of proliferating lens epithelial cells were noted in each lobe of the capsular bag, sparing the visual axis. The central clear visual axis at the time of surgery measured 1.5 mm. As anticipated, there was progressive widening due to contraction of the capsular bags, increasing the dimension of this clear area to 3 mm at 6 months. The clarity of the visual axis further increased to over 4 mm at 1 year. The amblyopia therapy was already instituted for this child in the post-operative visits. This child is able to walk, play, and catch objects with occlusion of the normal eye. There is good compliance with occlusion therapy coupled with spectacle correction of the affected eye. We also evaluated the visual performance of this child using objects of gradually decreasing size and of different colors. The child is able to pick up and play with the smallest objects easily using the operated eye, suggestive of a good visual performance. We conclude by stating that double crystalline lens is a management challenge which needs meticulous preoperative planning. This child achieved a gratifying visual outcome after implantation of a specially designed, customized intraocular lens followed by appropriate amblyopia therapy. Thank you.